Upcoming sessions. Next week, we have a session entitled COVID in Adolescence that will be moderated by Anita Juvati, who's one of our general pediatricians and part of our committee for this series. And she will be moderating a discussion between Jen Carlson and Rachel Goldstein from Adolescent Medicine, as well as Jack Turbin from Child Psychiatry. And that'll be discussing particularly some of the mental health issues facing adolescents during this pandemic, which have been quite striking. The week after that, two of our faculty from hospital medicine will be presenting on COVID in the developing world. That's Dr. Roshni Mathew and Vicki Ward. You can see on the left here, and this will also be in the chat, our text code and number for CME. Thank you, Ingrid. You can stop the screen share. As always, please put your questions in the Q&A. Today is an open forum, and I am thrilled to have back Dr. Yvonne Maldonado. Everyone knows Bonnie, and we've introduced her several times already in this forum and pretty much every other COVID forum. And she is a professor of pediatrics here, one of our senior associate deans, and is also the head of the Committee on Infectious Disease for the American Academy of Pediatrics. It's on the ACIP committee and the governor's vaccine committee. So brings a whole bunch to the table for our discussion today. And also Dr. Roshni Mathew is back with us. She is my co-chair for this series, is a clinical associate professor of infectious disease, pediatrics in infectious disease. Also is on service today, managing a whole lot of kids with COVID and, well, not a whole lot of kids with COVID, some kids with COVID, a whole lot of kids with other infections. And so thank you particularly, Roshni, for taking time away from your busy clinical day. And this is an open forum, so we have had questions that were pre-submitted. We're gonna try to tackle as many of those as we can. We'd also certainly encourage you to submit additional questions in the Q&A as we continue along our discussion today. What I'm going to do to start is show a couple slides, but I'm going to first start by showing this slide. Are you guys able to see this?
Yes.
Yep.
Okay.
Yes.
So we're going to try to cover, I think the themes of questions that got submitted mostly were around vaccination and schools. So those are going to be the two main themes of today's questions. But I wanted to just start with this. Whoops, sorry, this is the wrong one. I wanted to start with this. And I'm going to show, there we go. So this is our county dashboard showing hospitalizations for Santa Clara County. This is adults. It could include kids too, but the vast majority of this is adults. And I'm showing it in part because I think it's optimistic and demonstrates how we have really made a lot of progress during the last month or so. But it's also, I show it because to me, at least, it demonstrates that to some extent, at least, this virus has been somewhat unpredictable in its behavior. And so I wanted, maybe Dr. Mathew, I can just start with you to get your reflections on what we're seeing now, what we've seen over the last couple of months. I've highlighted here a couple important dates, including the two major holidays, as well as the initiation of the state and county stay-at-home order in early December. Anyway, Roshni, tell me what you see when you are looking at this graph.
Yeah, I've looked at these graphs a lot, and for sure I thought after Christmas that we would see another huge surge. We are walking those dates at the moment, and we are actually not seeing it. So I'm pleasantly surprised. In fact, all hospitals had prepared for a surge that would be worse than the Thanksgiving surge, but thankfully that did not happen. So I am not entirely clear. We cannot say the vaccinations because that was a small subset of the population that got vaccinated during this time. So I am not sure as to why we did not see the huge spike. We do know that there was a lot of travel around Christmas and New Year. So it's, there were a lot of people who continued their social activities during that time. Yeah, so it is definitely not what I thought would happen.
Yeah, so a big jump after Thanksgiving, although you could certainly make the case that some of that increase was happening before the Thanksgiving holiday. Certainly continued to increase after that. And of course, also worth noting that hospitalizations lag from cases. But Dr. Maldonado, I know you've been following cases very closely too. Any reflections on our trends?
Well, I think, you go back to March when we thought we were, really afraid of this new virus, and we thought we were facing a very big curve. And you can just see how this third surge is really, it shows the power of exponential growth, really. That's basically it. And we talked a lot about it back in March, and indeed we were seeing exponential growth back then. But this reflects exponential growth plus disseminated community transmission. So again, this is, I think it, and the other thing I think it shows is what we said as well early on. You can model things only so far. The models start to break down after about a week or so, because you can't predict not only viral characteristics, but you can't predict behavior. And a lot of this is about behavior.
Any thoughts on the downtrend that we've seen the last couple of weeks?
It's hard to know for sure, but I do know, when talking to my colleagues in public health around the country and other places, this is the standard old strain that we have had around for a year. I mean, the new variant really is just starting to come in here. It was introduced in the UK and South Africa, probably in October, between October through January or so. But I think this just reflects our inability to really contain movement of people. Yeah. And what my friends were saying is that at a certain point, it was just very tiny gatherings, one or two people getting together without distancing or masking. And if they were having dinner, you can still do that, but you need to stay 6 feet apart. So that was less likely to happen before Thanksgiving, because there were just less people infected. You needed more, you just need to get together with more people just to statistically be around somebody who was sick. So that just changed dramatically. And again, the power of exponential growth given behavioral changes. So I think that a lot of the driving factors here were COVID fatigue and a holiday season where people just get together with families quite a bit.
Yeah.
And maybe now people are back at work or not around families as much, or they've already developed some degree of local herd immunity. I'm not saying, that we have enough immunity and we want to wait for vaccine herd immunity, but they're probably depleting a lot of the local susceptibles within their small pods.
Given that this is hospitalizations, and that even though the total number of vaccinations administered at this point is still relatively low, we have of course targeted. First we targeted healthcare workers, but at least have targeted some of the higher risk for being hospitalized. So is it possible that some of this downtrend is a vaccine phenomenon?
I think it's really hard to say that that's the case. You really need really high levels of herd immunity to affect anything like this. And we really have only vaccinated about 5% of the US population. I mean, I do think where it could make a difference is hospitalizations and deaths. So because long-term care residents were first to get vaccinated, I'm thinking that we might have some impact in that area, but certainly not in the general population. I think now, since December, with vaccination of 75 and above, those people account for 80% of hospitalizations and deaths. So I do think that'll help have an impact on our healthcare system if enough people in those age groups get vaccinated.
Great. Well, let's continue to talk about vaccines, and I think I had shared this table with you guys by email in advance, but even if you haven't had a chance to look at it. This is by, this was actually on Twitter by Monica Gandhi, who's an infectious disease up at UCSF. And I liked it because it's a good summary of the different vaccines and emphasizing, I think a couple of important findings so far. Certainly the efficacy on the far right column here, but also the numbers on severities. One of the submitted questions, which had actually been posted last week as well, had to do with whether, how sick the people are getting in the vaccine arms of these trials who wind up getting diagnosed with COVID. And so, Dr. Maldonado, do you want to try to talk us through kind of some of the summary findings here and maybe addressing particularly severe disease as well?
Absolutely. So I think the big candidates right now are there's basically three major platforms. So first of all, you've got your mRNA platform vaccines. Those moved really quickly, partially because those mRNA platforms are easier to manipulate and get into production rapidly. And so those are the Moderna and Pfizer products. Those are simple mRNA, synthetic mRNAs that reflect the conventional COVID, SARS-CoV-2 virus. They're encapsulated in a lipid nanoparticle, and they're injected, and they serve as mRNA templates for spike protein production, and then a protein is expressed and you develop T and B cell immunity. The AstraZeneca and Johnson & Johnson are adenovirus vaccines. The AstraZeneca is a chimp virus, so it's not thought to be highly prevalent in people, and that's important because you don't want to have pre-existing immunity to the vector, because then you may not make a robust enough immune response. So that they also have the cDNA complement of the spike protein RNA inserted, and then you get basically the same thing. You get expression of a spike protein. And then the Novavax, and I won't talk about the Sputnik because I don't know enough about it. It is a combination of kind of the vectors used in the AstraZeneca and J&J. Apparently, it looks like it has good efficacy from what I understand. I haven't read their papers yet, or if they have any. They're apparently talking about pretty high efficacy. But the Novavax, and the other one that may be coming along down the line is the Sanofi. And those are both recombinant spike protein vaccines. They're all pretty efficacious. I think, the range is, as you see, the range there is somewhere between 60 and 95% efficacious. The Sputnik, again, claims to be 91.4. I haven't seen the data. And when you look at the efficacy against the variants, you want me to talk about the variants? I can talk about that.
Please, yeah.
So the efficacy against the variants is really interesting. I was just listening to one of our former fellows, our residents actually, Philip Dubovsky is the CMO of Novavax, and he was presenting this at our COVID vaccine network meeting earlier this week. And depending on whether because they started their trials in the middle of the variant evolution, you can actually get efficacy estimates around some of the variants, people who got infected with variants. So some interesting things is that so far, all of the Moderna at least for sure has published a statement saying that their vaccine does seem to be still effective against the UK variant. But we haven't seen those data. Pfizer and the others haven't said much, but Novavax did talk about the UK variant in at least some of their notes that they talked about in their vaccine network. And it does appear that there is about 60% efficacy. It's complicated. It's about 60% efficacy against the South African variant, but much higher efficacy against the, you see it there, against the UK variant, and pretty good and very good efficacy against the conventional strains as well. So there is evidence that there's there's decent efficacy. Remember, back in last summer, we were talking about hopefulness that we would have a vaccine that would be 50% effective. So the fact that we're worried that 50% is not good enough is an interesting sign. It shows that we have very good vaccines out there. But we're also seeing that virtually all of the cases, at least the Novavax cases, none of them were serious. All of them were mild and moderate. And actually very few moderates, really mostly mild cases. And really all of the cases among the vaccinees have not resulted in hospitalizations or death. So if anything, remember, one of the aims here of vaccines is to prevent hospitalization and death. Obviously, you want to prevent transmissibility, which I think AstraZeneca seems to indicate that they could probably do. They reduce transmission, infection in vaccine recipients by about 2/3 after the first dose. It actually dropped to 50% after the second dose, which maybe indicates just, continued exposure. But the other thing you want to prevent is serious illness, which could lead to hospitalization and death. And so I think we're doing reasonably well on all of those fronts right now with all these combinations of vaccines. I think the big question is, when are we going to get enough of these vaccines out into the US and the world? So one last thing I want to share is there will be a talk about global HIV, global COVID, sorry. And before, back last summer, there was a graphic that I didn't show here, but looking at how much vaccine has been allocated, already purchased. This was last summer before anything had been licensed. And the UK had 5 doses per capita purchased already. The US, the European Union, and Japan had 2 doses per capita purchased already. And everybody else had way less than 1. So that's a big issue, because as you can see from the data around the variants, if we don't vaccinate everybody in the world, if you don't want to be altruistic, at least you have to realize if you're not going to watch what's happening on the other side of the world, it will come in and visit us at our doorstep. So we need to make sure, for many reasons, that everybody gets access to vaccine.
Thank you for that last point. One other thing that I think we just learned, at least about AstraZeneca, was some of the questions that had been unresolved prior to this about transmission, and at least suggesting that for AstraZeneca that the even asymptomatic carriage was substantially lower in the vaccine arm there. So that's promising news as well. So good, lots of reasons to be optimistic, but also the equity angle persists. So we will get to a few more, and of course the uncertainty around children continues to persist as well. I want to just show one last slide, because we had a lot of questions about side effects, and in fact, I think one of the questions asked us which one we got and whether we had side effects. And I think it's important to not necessarily rely on individual reports of side effects, given that we have data from tens of thousands of patients in randomized fashion, and given that a lot of these symptoms they are here at baseline. So this is a slide that we put together that lists the side effects from the Pfizer trial as reported in the New England Journal. And I've tabulated on the right here what we would call a number needed to harm, the calculation up there. But this basically just compares the absolute risk of a side effect in the vaccine arm to, or the difference between the absolute risk of a side effect in the vaccine arm to the risk in the placebo arm. So for example, if you were to look at, say, fatigue, you can see in greater than 55 years of age, 25% or 23% of people have fatigue at baseline in the placebo arm. So what we're looking at is a difference in risk between the vaccine arm and the placebo arm. And what I put here is just for some of the commonly reported side effects, how likely you might be to experience these side effects. So put into sort of plain language, pain is very common. And what this means is 1 in 1.5 or 1 in 2 people will develop pain at the injection site. And that is and that's common and to be expected. But for some of the other more systemic complications or side effects like fatigue, it's about 1 in 3. Headache, it's about 1 in 4. And then for chills and fever, whoops, lost my screen, but that's okay. For headache and fever, it's a little bit less common. So I think that the takeaway from that, have I stopped sharing? I think I have, yeah. Is that rely on the published data for assessment of side effects more than individual anecdote. Anecdote tends to spread, particularly on social media. Obviously, we need to pay attention to the very, very rare side effects that are happening, and reports of those surface. And I know the ACIP and others are tracking those very closely. But Dr. Maldonado, any developments from your perspective on serious adverse events from immunization, anything that we need to be tracking more closely or worry about?
Well, I think the issues are really around anaphylaxis. I think that's what people really have been bringing up the most. And the risk there has, and Grace Lee obviously is chairing that group. But the risk presented last week's ACIP meeting for anaphylaxis for Pfizer seemed to drop from 11 per million doses to somewhere like, I think, around 8 per million doses. And then for the Moderna, it's about 2.5 cases of anaphylaxis per million doses. But again, all resolved, all treated in the outpatient setting. So we know that the baseline rate for vaccines is somewhere between 1 and 2 cases per million, with flu vaccine being at 1.3 cases per million. So higher, but still treatable. And I think the risk, 80% or so of the people who had anaphylaxis were, well, it was predominantly women, and 80% had some evidence of allergies, severe allergies to food or other environmental factors.
Good. So I think, certainly expect to have some, not uncommon to have some element of side effects, but severe side effects, very, very rare and continuing to be tracked closely. So as far as the messaging, that was one of the questions we got. How can we message it? I think, is that a fair surmisal at this point?
Yeah, absolutely. I think these are very safe at this point. Again, the anaphylaxis, we just need to make sure that we screen people. All of you who've gotten vaccinated know that you've gotten the questionnaires and when you come in, and then people need to sit 15 or 30 minutes to be sure that they don't have any reactions that can be immediately dealt with. There's an algorithm now for people who do experience, say, anaphylaxis or allergic reactions, and whether or not you should refer them to an allergist, because some things should be referred, others don't necessarily need to be, and that's, I think, already been circulated. It's in the process of being, I think, put out by the 2 hospitals. The other signals, I think, were Bell's palsy and Guillain-Barré, but those have not really shown up to be major issues at this point.
There's a question that was submitted that also came up last week a couple times, and people just asking about whether the degree of symptoms after the vaccine correlate with the immune response. And we stated last week the answer to that was probably not. And that, there's no evidence of a impaired immune response in people that don't have side effects.
Yeah, absolutely. That's true so far. Now, it is interesting, though. There is a paper a preprint that came out, I think, I can't remember, maybe this week. I don't know. What's today? Thursday? Yeah, I think it was this week. From looking at vaccination, people who responded. So people who had COVID before they were vaccinated with, I think it was the AstraZeneca vaccine, had had more reactions to the vaccine than people who hadn't had COVID before. And there also was a more robust immune response. But again, it's a preprint. I'm not sure. I don't know whether those two things will correlate with each other.
And as I recall, that led to some discussion about whether in those people one vaccine would be enough.
Yeah.
So that'll be an interesting.
And I think this question of one dose keeps coming up. I think it's a good question to ask, but we've decided to just keep trying to give 2 doses for the time being, because I mean, I think for ramp up for the whole world at some point, maybe 1 dose might be important, but I frankly don't think it's a matter of supply. I think it's a matter of or production. I think it's just a matter of dissemination of vaccine at this point, really.
On this line, the question just submitted about if someone was COVID positive, how long would you wait, and do they need any testing before they would get the vaccine?
Yeah, well, the recommendation has been moving around a bit. So I think they're talking about, it's, I think the latest one, is it 42 days now, Roshni? They said 90 days, and now I think they're saying 42 days.
Yeah, the CDC's guidance, I think, still says that once you're over your acute illness and have finished your isolation, you could get it, but you could defer it for a period of time. So I think we've gone back and forth because of that language, which is a little bit and not as clear. So at this point, I think we last landed on give it a month after you've experienced COVID before you come in for your vaccination. Because by then, if you're going to develop late complications like MIS-C or MIS-A, you would have, given that opportunity for that uncommon complication before you get a vaccine. So the thought was to just give that period of time of about a month before you get the vaccine.
Yeah, we went back and forth on that also because we don't really know what your T and B cells do, like how long does it take? And if you look at the literature, and there's not a lot of literature in this area, but if you look at how long does it take to prime your T and B effector and memory cells, sometimes it looks like the longer the better. So there's arguments both ways, and we just don't know. So we just said, like Roshni said, a month, once you're feeling better, get your second dose. And there are some data from Johnson & Johnson now showing that when they, no, it's not Johnson, it was AstraZeneca again. They deferred their second dose in the subsequent studies. They deferred the second dose by 3 months, and they had a pretty robust immune response. So I think the data is getting a little messier around what should we do. I think we should just stick to what the FDA and CDC guidance is for now until we have better data for our products that have been studied and reviewed by the FDA.
And just to answer that question, complete the answer, we would not recommend any kind of testing before the vaccine. No. So no NP swab, no serology, no strand specific, none of that is required.
Nothing.
Okay.
It's a lot of expense, and I don't think it's going to tell you anything. I mean, it's not going to give us information for which we will change our decision, because we don't know what the right results should be.
And lots of questions actually about testing that, Roshni, I'm going to push you on a little bit later, particularly as relates to school and daycare. But I want to just finish up on vaccines. And we haven't really talked about kids yet. We did spend a fair amount of time talking about the pediatric landscape last week, and we'll do that. We'll continue to do that probably every month. But Bonnie, maybe any quick insights into the ongoing status of pediatric involvement, and when there was a specific question on when 12 to 15-year-olds might actually be getting immunized.
Yeah, so we have a new AAP president, and we've asked her to rewrite a letter. We drafted a letter. We wrote a letter on behalf of the prior chair, and the president of the AAP, Sally Goya. And so we sent that letter to HHS and Operation Warp Speed. That was a year ago, more or less. No, last summer. But we'd like to have this new president send that letter again, or a version of it, to the Biden administration as well, to their COVID task force, because we want people to remember that children need to be part of these clinical trials. I know that there are efforts by all of the vaccine companies to do that. And at last week's CDC meeting, the NIH showed a list of all of the companies and what vaccine trials they're in the middle of doing. They're addressing the 12 to 15-year-olds for sure, and most of them are starting to think about moving into the younger age groups. So we really want to get those vaccines moving out. And the question will really be whether to do immunobridging studies or safety studies or a combination. And by immunobridging, I mean you would have to find a correlate of protection, which we don't really know that yet. We don't know what, for example, what titer of antibody, which antibody to measure, what the titer of protection would be. So as soon as the companies, and Pfizer and Moderna are actively looking for this, I imagine the others are as well, if we had a number to look at, that is, if you developed a titer of, for example, for measles, it's a 1 to 120 dilution of neutralizing antibody, that's considered protective. Then we could use that to do just immunobridging studies where you vaccinated kids for safety and then looked at the level of immunity and see how the duration would be. And that's the idea, is that hopefully they can get some degree of that in future studies so that you can move more quickly into the younger age groups.
Any trials that you're aware of that are going on locally that people could involve?
Yeah, so we're actually next week we have a site assessment for the Pfizer trial. I think hopefully we'll be part of the Pfizer trial. They have to select us. We're selected. And we've made it to the last round, and we're going to do one last review, and hopefully we'll be part of those trials. And they're not starting until I don't know when they're starting. They haven't said yet. But I think they said, we'll see. There's also the Johnson & Johnson as well, and we're that we are not part of those pediatric trials, but we will probably be part of the Pfizer trials. We also will be part of the Sanofi trials, but they're just starting to look at adults and in the US, and those won't start till later in the spring.
There were a couple of questions about children with medical complexity. One person just asked whether their own child who had a complex illness, this Stevens-Johnson, if there's anything that we know yet about whether immunizations would be contraindicated. I think probably early to say at this point, but will we be vaccinating our kids with medical complexity earlier at the same pace or later, if at all, than healthy children?
Yeah, it's up to the companies. We don't know. I mean, I imagine they're going to want to go with the healthy kids first. But I don't know. We just don't know what they're planning on doing right now. Most of the kids that they're enrolling now, the 12 to 15-year-olds, are healthy.
And a related question to that has to do with the caregivers or parents of kids with medically complex children. This is from Jean Chia from our complex care clinic, and talks about how these parents have been notified that they are considered to be healthcare workers and eligible under phase 1A, but that at Stanford, they're now having a hard time getting these parents in to get immunized, and they've been turned away from other sites, suggesting that maybe Sutter was still accepting some of these patients or parents. But is there a way that we can advocate for parents of medically complex children to get them immunized sooner?
Yeah, so that's a really complicated question. And we've been it says really literally today, there have been at least 3 different email exchanges from the state, the county, Stanford Healthcare, and Stanford Children's Health. It's very messy. The issue has to do with the fact that the original tiered structure was healthcare workers go first, along with residents of long-term care facilities. And then you go to 75 and above, and then you go to 65 and above, et cetera, and under essential workers and complex medical conditions. And the reason is you're trying to do two things. One is you're trying to maintain your healthcare structure, and you're trying to reduce the hospitalization and death rates in the population as a whole. And we know that 75-year-olds and above account, as I said before, account for 80% of the, oh, sorry, I said that in my class that I just taught, sorry. So 80% of the deaths and hospitalizations occur in people 75 and above. So the biggest impact is going to be long-term care facilities and people over 75 in terms of keeping people from getting hospitalized and dying. So what happened was very recently, like a few weeks ago, the Department of Health, without telling anybody, just decided to make every caregiver of any child with a huge list of conditions. And actually the list isn't that long, it's reasonably long, but they say not exclusive. So meaning you could probably add lots of other conditions in there. They made them healthcare workers essentially. So they put them right up into that 1A category. We don't even have enough vaccines right now to finish 1A that we have right now. So I absolutely think we should advocate for those individuals. And I think, but the question is, how do you structure that? How do you tier that out when you have, you know, in California alone, we have 2 million healthcare workers. And we are just getting to the point where there's enough vaccine for them, plus the 75-year-olds and above. So trying to parse out all of the parents of kids who have conditions, which are probably in the, I would imagine, tens to hundreds of thousands around the state alone. How do we do that? I think is important to bring up. And we're trying to have this discussion with the county. The county is not making this mandate, and they don't know how to manage it right now because it's they're really trying to manage at a higher level. So we have a vaccine governance committee here that's represents both hospitals, and that's the group that's trying to figure out how can we offer these families the ability to get vaccinated. And as long as they have designation of 1A, they are eligible, so they should be eligible to go in. And now the county is saying that the state has told them that people from any county with documentation that they meet criteria can go to any county facility and be vaccinated. So that just happened in the last day.
I want to, there was a question, Roshni, about testing in schools, and I want to shift gears and talk about that because a very similar question was submitted by at least 3 pediatricians, and it really involves what seems to be a very common scenario, which is that a child had previously had COVID, they had gotten better, and now back in school or daycare, and then develop new symptoms, new common fever, URI symptoms, nonspecific. And now the PCPs are being asked to clear these children to get back to school or to daycare, and limited or constrained by the fact that if they were to test them again for COVID via an NP swab and PCR, there's a high probability that there would be residual RNA and that the test would be positive, but not necessarily evidence of contagiousness, or that is what's causing the new symptoms in the child. And so people are feeling stuck and handcuffed about exactly what to do here. And people are specifically asking and mentioning that the strand-specific test, which you might want to talk about a little bit, but that is one way we've addressed this on the inpatient side, because the strand-specific test helps us differentiate replicating virus versus non-contagious virus. But that's expensive and it's only run a couple times a week. So people have asked about the cycle time that we've heard Ben Pinsky talk a fair amount on Medicine Grand Round, and as one way of kind of assessing viral activity. But what are the pediatricians supposed to do in this scenario?
Yeah, so this is a very complicated question with many different questions within that question. So I will address the cycle time for one. So not all our PCR machines necessarily have cycle time output. So it depends on which machine they ran the test on, at least at Stanford Virology Laboratory. That's one issue. So not all samples will have a cycle threshold. The strand-specific testing is a innovative test that our virology lab developed, so it's not something that other centers do. We are still trying to clinically validate it, but all of the issues with strand-specific is true. So logistically, it's done only a few times a week. It is an expensive test, and we don't understand insurance coverage for that. For example, in the outpatient setting, because it would still be considered a research test. In our inpatient setting where the stakes are high in terms of the child getting aerosol generating procedure and being around multiple other patients and care providers, we do use strand-specific test. And I must say, I am yet to be surprised by the result of a strand-specific, in the sense that we have had many patients that have completed their period of isolation of 10 or 20 days, depending on their immune status. And they come back for a procedure 30 days later, and they have had a PCR and it's positive, and we reflex it as strand-specific. It's always been negative. The times we have seen a detected strand-specific has been a patient that I would have guaranteed is still shedding infectious virus, are severely immunocompromised kind of population. And even the immunocompromised, there is a very specific subset of patients, for example, that we have observed have the trouble with SARS-CoV-2 being persistent. So that I would say about strand-specific. So I would use that. I would not really use that much at all in the outpatient setting, to be honest. So in terms of a child that had COVID and a month later has URI symptoms, I just feel like that's a tricky one. I would say that do not do SARS-CoV-2 testing on that child unless, if you have an alternate explanation, if the child has a history of allergies or something like that, I would consider the alternate diagnosis. I would ask again, has there been a new exposure that you know of with COVID? So if there is any concern that this could still be for some reason an unusual situation where there could be a reinfection, which by the way, CDC says we shouldn't have for 3 months. So I would just do the SARS-CoV-2 testing in that instance if there is no alternate explanation. However, a child who is symptomatic should not be going to school anyway. So I would just use that. So I would, practically speaking, and this is what I'm just imagining a child coming to clinic. I would say, well, rest at home, see how you feel tomorrow. If all is well, I would not test that child for SARS-CoV-2 because of the issue of persistent shedding that we know can happen up to 3 months. Because once you get a positive test, I am not entirely sure how you can avoid the isolation for that child, because the CDC does have guidance around this, the 10 days of isolation. So I would use the common sense approach again, it is going to be very tricky, and this is like a simplistic way of talking, but I do think that the persistent shedding does happen. We've seen numerous cases of that. So I can imagine that to be true in the outpatient setting.
Yeah, I empathize very much with the plight of these pediatricians, and I understand it's a lot, but certainly not sending a kid to daycare or school if they're sick makes sense. I guess the question is, if let's say it is some other circulating virus, are we worried about, once they have recovered and are asymptomatic, are we worried about them transmitting that virus, be it rhino or the few RSV or whatever? But you know, in prior years we've said once you get better, go back to school. Is that fair here?
That is fair, because I feel like when we look at how the viral load is in relation to symptoms, you have to worry about the just pre-symptomatic phase. So if you consider the graph like this, that's why we say 1 to 2 days prior to onset of symptoms, you're actually quite infectious, and then your viral load keeps on going up, and you're actually most contagious during the first 2 to 3 days of illness, and then you rapidly decline in terms of infectiousness. So I do think that is true about SARS-CoV-2, and that's true about influenza and RSV. And so if you're symptomatic, do not go towards other people. But once you've recovered, the risk of contagiousness drastically reduces, whichever virus it is.
Great. Well, that's really helpful. And I'm going to just ask another question about testing while we're here from Grace Chang, who asks about for kids in school getting screens for COVID. It appears all tests are currently only EUA and approved for symptomatic people only. Any recommendations for what to do for screening, but also are any tests getting evaluated for false negative rates in asymptomatic people? And I'm not sure if she means point of care rapid tests, and whether I wasn't aware that some schools are doing that locally.
So let me just mention that this keeps coming up with the American Academy of Pediatrics. We're getting a lot of the same questions from providers around the country, and the Academy really hasn't weighed in because there's just so many different tests out there. And in general, most of the tests, if not all, have been only EUA approved, as you heard, for symptomatic, with symptomatic data. It's really hard to collect asymptomatic data. We've been doing it since the beginning of the pandemic, and it's really hard to collect out of the hundreds of people you swab to even find, 10 or 20 people who are asymptomatic shedders in your random population. And so it's really hard to know. And if you look at the data from CDC, these tests don't perform very well. Clearly they don't perform as well as PCR. So there's a lot of lack of sensitivity. The specificity tends to be really good. So if you have a positive, in general, they tend to be very good, but they may miss a number of cases.
To emphasize on that, Bonnie, that I know we've emailed about this before, there is fairly good reason to think that the false negatives are occurring in situations where the viral load is very low.
Well, that's probably true. Yes, exactly. So I was just going to say that. So there's probably, again, we don't know this for sure, but it appears that may be, again, there's a lot of people, there are people who just don't like point of care and other people who just think it should be done. And I'm not sure where I stand on this. If you look from an epidemiologic perspective, any test is better than no test if you're looking for population-based surveillance. So for example, if you're looking at trying to keep kids in school and you're doing symptoms checks at home, I'm not sure the temperature checks, well, maybe temperature checks at home, but anyway, symptom checks. And then if you could do like a rapid test on kids going to school in a large group, right? Not just, I would never use these for example, for outpatient clinics or for hospital-based settings, because you really want to use a PCR there if you think somebody's really infected and sick in the hospital. But for population-based studies, all of the models really show that testing, if you have capacity to do frequent testing, even with a point of care test that's not great, it still pulls out more people who are infected out of circulation than not doing testing.
Exactly.
So I think in the big picture, and I have to be really careful to say that that's a big picture. That is not saying that the individual child is not infected, but that if they're infected, you're going to miss them anyway if you don't test them. And if you test them and they're negative, you're still going to be using PPE and distancing at school. So, and we know, we're doing a school-based study right now, and we haven't seen any transmissions at the school. We're testing the kids on a weekly basis, and we just haven't seen any infections. And people are staying home if they're sick. There have been transmissions, but they haven't been at school. So I think that, the regular routine stuff is helpful. And if people are worried about testing for school-based needs, we're doing it for research purposes only. We don't know yet if it should be done routinely. And even if you wanted to, those tests are very hard to get right now. So I do think with a carefully planned district-wide policy of doing regular testing every so often, and then pulling people out who are sick, and then those pods get isolated for X number of days, all of that, that could be useful, but you need to have all that in place. You can't just go out there and start randomly testing people with those point of cares if you don't have a way to back up what to do next.
Well, and just to emphasize, because there continues to be questions about sending kids to school, and we've talked about this a lot, but overwhelmingly now the data is suggesting that if it's done right, and you just said this, but I just want to reiterate, since we get so many questions, if it's done right and recommendations are followed, transmission is incredibly low in schools.
Absolutely. I don't know. Roshni, what do you think?
Yes, sorry, I was responding to a question.
Oh, sorry.
It's okay. Was the question the transmission risk from children being very low?
Yeah, going to school. Yeah, going to school.
Yes, absolutely. I do think that the risk from a child being the index cause of other transmissions still continues to be, from all reports that we have seen so far, continue to be very low.
There was a question also about someone was concerned about sending their kid to preschool if the teachers themselves aren't immunized, but I don't think we've seen a ton of teacher to student transmission.
Yeah, this issue about everybody has to be immunized before they go back to school. I'm going to be very careful about what I say here, but that's a new issue. That was never part of the issue around transmission. We work. All of us work with people every day, and we're obviously we have more PPE, but we're not wearing all that much more PPE in our daily interactions, and we're not getting infected. And so I just think this idea that every single person has to be vaccinated before they go back to school doesn't, you could use the same argument for going to a hair salon or an outdoor restaurant. I just think, obviously people say, well, no, it's different because you have prolonged contact and all of that, but we're doing this in the hospital all the time, and all the healthcare data in countries where there's good, good PPE and all that, and that's the big variable there. If you have good PPE, if the teachers are masking and distancing, they're not sitting in the break room together having coffee, people are doing this, staying home if they're sick, they're distancing, they have pods, that is not leading to infections. So I absolutely think teachers should be vaccinated. I think that's the only way you should return to school? I do not.
Dana Weintraub asks if the low transmission that we're talking about includes middle and high schools, and of course, because so many of them have been closed, that's been harder to assess. But any thoughts on that?
It's hard to know. I mean, we know that from data from China and mostly from China, because they had a lot of schools open, and some European experience, the middle schoolers just have higher transmission rates. I don't know if that's a biological difference or if there's also behavior differences. But I think that would be harder to enforce just because of the behavioral issues around older kids anyway. But, and also because you got to move around a lot more. So the younger kids can stay in one place, whereas you get to middle and high school and they need to move to they have homeroom and different rooms, et cetera. So that's a tougher question. I think we need to figure that out. I think that's where actually frequent testing might be useful. That's what we're doing here on campus, for example, for college, for undergraduates and graduate students. So that might be one way to test that out, that's where I might really think about instituting, twice a week rapid testing or something like that.
Well, we have gotten through all of the pre-submitted questions, and we have, it looks like, only 7 questions in the today's entries left. And so with 6 minutes, it's about 1 minute per question. Any comment on the 2 Merck vaccine candidates that were dropped due to low efficacy?
Well, I just think they were slow out of the gate. They just started late, and I just think they realized they weren't going to be able to catch up. So that's all I really know.
A question back to variants. How aggressively are we looking in the U.S. For variants? I think we had a similar question in the chat about vaccines and variants. We've talked about that a little bit, but anything else you want to add about the variants?
Yeah. So Ben Pinsky has done an amazing job of picking up screening for variants. I think we've screened over 2,000 samples now. We're not doing all of them because it's hard to screen for variants for every single sample, but he's taking a random sample of isolates and testing them for the current variants that we're seeing. And we're actually finding variants that are homegrown variants. And again, some are concerning, some are not. We know viruses are going to mutate. The question is, are they going to interfere with the immunogenicity of vaccines? And the companies are already working on that as well. So we are looking. There are some networks around the US. They're not super transparent. I tend to go to this one website called nextstrain.org, and they tend to show you where what the variants look like. And then there's another website. The CDC has a website looking at variants across the country, just numbers wise. I mean, we're going to start to see these viruses start to predominate because it's natural. It's convergent evolution. You're just going to see the hardy. It's like antimicrobial resistance. The hardier strains are just going to evade selective pressure.
Two different people asking about signing their kids up for the Pfizer trial. I mean, we don't even know if we're going to be a part of it yet. But,
yeah, I'm hoping we will. Hopefully we'll look really good to them next week. We're already doing a Pfizer trial for pregnant women and RSV. So I think because we've been doing, thanks to Natalie Aziz and her team for a great job, we've been doing really well with that trial. And so I think we have the capacity to build it out, and our team is really ready to go. We probably do it over at the CTRU. As soon as we find out, you guys will be the first to know, because we really want to enroll as many kids as we can. And we think the vaccine looks pretty safe, and Pfizer has done a good job of doing good safety monitoring.
Roshni, this one's for you. Comment on double masking recommendation by Dr. Fauci, or put on your infection control hat here.
So I just also live typed the response. I believe Dr. Fauci later went on to say that he would, whatever the CDC says is what should be done. The CDC has not changed its guidance on masking at this time. So right now we just do the regular masking for all patient interactions unless they are undergoing some sort of aerosol generating procedure, in which case we wear N95. We have not supported any kind of double masking. But if CDC were to change its stance, we will follow accordingly.
And just around that issue, I think people are concerned about the variants. Now we have to remember that right now we don't know if the variants are more likely to have higher sustained viral loads, or are they more likely to be aerosolized, which would indicate that you need more masking. We don't think that's the case. What we think is happening is that these mutations are happening at the receptor binding domain, where the ability of the virus to adhere to the ACE2 receptor and to stay adherent, and then initiate integration of RNA into the cell. That's the process where I think the variants are having the effect. So therefore, the question is more of, once the virus gets into your host cell, it's maybe just more likely to stay attached and to infect. We don't have evidence yet. I'm not saying there won't be, but we don't have evidence yet that it's more likely to be spread to others. I mean, I would much rather tell people just wear your mask more often and be careful all the time than to say wear more masks, than you have been. If people are pretty fastidious and careful, I would prefer more people to do that than to, because if you push people too hard about, well, do more stuff, then that just pushes the people who are on the brink of not doing anything at all. So I'd rather have more consistency with the current recommendations than, if people feel like they get an additional sense of security with a second mask in the outside the hospital, I guess, but that actually interferes with our N95s and other things that we already do in the hospital. So we don't really have any data to support that yet. I don't know, Roshni, what you think?
I agree with that.
Any data on antihistamine use prior to vaccine administration for people that have, say, anaphylaxis or severe allergies?
Yeah, so I'm not an allergist, and I think Kari Nadeau is the best person to comment on this, and she has mentioned that some people do take antihistamines before. If they are allergic, they have a history of allergies, they can pre-med, and it won't prevent anaphylaxis, but it could help with some of the other allergic reactions that people might have, such as potentially, I don't know, maybe angioedema, I don't know, but other allergic type reactions. But it won't prevent or mask anaphylaxis. So I would consult with my allergist, I think, or my primary provider. And we will have guidelines from both hospitals around this issue.
All right, well, we've sort of addressed some of the questions, the remaining 3 questions, so I think we can call ourselves done. We're a minute over anyway. So thank you guys, as always, really helpful. Thank you everyone for submitting questions, and we will see everyone next week.
Thank you.
Thank you. Take care. Bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.